Hello friends, today we are going to discuss about Generalized Anxiety Disorder, also called as GAD. I am Dr. Suresh Badinmat, Professor of Psychiatry, working at NIMANS, Bangalore. In this video, I'll be discussing about Generalized Anxiety Disorder, what are the important historical aspects, how to diagnose, what is the neurobiology, what are the comorbidities associated with GAD, course and outcome, and treatment of Generalized Anxiety Disorder. Before we enter into GAD, let's understand what is anxiety. Anxiety as an emotion, it is characterized by feeling of tension, worried thoughts, and physical changes such as increased blood pressure, respiration, sweating. Anxiety plays an important role in survival of the species. Whenever an animal or a human being is faced with a potential threat, maybe predator or maybe a death. In such a scenario, anxiety plays a crucial role. This anxiety triggers a cascade of events. This triggering induces anxiety, increased heartbeat, increased respiration, muscle tension, and very importantly, it acts in the fight, flight, and freeze reaction. Let's understand this fight, flight, freeze reaction. This concept was given by Walter B. Cannon. Mr. Walter said that whenever there is a threat perception occurs, the amygdala starts firing and it sends information to the hypothalamus. From the hypothalamus, the pituitary gets information and a series of events occurs. And there are important hormones released through adrenal cortex along with adrenaline, noradrenaline, and cortisols. This is which occurs within a few seconds. But at the same time, sympathetic activity also starts. This results in dilation of pupil, dry mouth, fast breathing, increased heart rate, tensed muscle, slow digestion, sweating of palm. This digestion becomes slow because the entire blood will be redirected towards the skeletal muscle so that the animal is ready for fight or flight or freeze. In such a scenario, whenever there is a threat, this anxiety is a survival instinct. So anxiety as an emotion, whenever there is a predator or an incoming danger, or it may be a stress, this sets off an alarm in the body. This alarm is also considered a very important stressor. That means how to manage stressor, how to cope with the stressor. As I mentioned, whenever there is a stress at this point of time, in civil society there are no predators, but however, there is events of stress which occurs from morning to evening. Whenever there is a stress or abnormal threat perception or even a normal threat perception, in such a scenario, the hypothalamus sends signals to the pituitary gland, being the master gland of the endocrine system, will give information to the various parts of the body, which results in the cascade of events. So, this prepares the body to respond to the threat. So, now with this background of anxiety being a survival in nature, but at the same time, if this anxiety does not subside, and this abnormal threat perception occurs at every point of time and every second, then the generalized anxiety disorder comes in. That means this anxiety, which is normal for the survival of species, at the same time, if this anxiety does not subside and every point of time it sets off alarm, then there will be a huge issue. Then this generalized anxiety disorder comes into picture. The historical aspect, if you look at the generalized anxiety disorder, it was started somewhere in 5th century. Here, the Celsus Aurelianus clearly said that the term pantophobic, he used this Latin word and he said that pantophobia is a pan-anxiety. Again, this was used by various English physicians and it was considered to be one of the important, that is, anxiety everywhere or afraid of everything. Hence, either it is considered as panphobia or pantophobia. Here, over a period of time, the Greek word, the worry or preoccupation also came into existence. Hence, panophobia was equated to George Beard's neurasthenia. That means a state of a vague but permanent anxiety or terror or a free floating anxiety with generalized weakness, fatigue, and tension. So, this George Beard's neurasthenia was also an equivalent component, component of GAD was considered. But however, Sigmund Freud also explained about this by telling that anxious expectation or anxiety neurosis. Here he mentioned it arises from psychodynamic theory. We will not go into that detail, but however, you should know the evolution of this generalized anxiety disorder. But however, this generalized anxiety disorder entered into the diagnostic classificatory system. In DSM-1, especially, it was considered in a broader term called as anxiety reaction or psychoneurotic disorders. But however, it continued, and in DSM-2 it was considered as neurosis. Later, in 1975, the first time there was an attempt to understand generalized anxiety disorder. And the Spitzer et al. In 1975 separated GAD from panic disorder. And in DSM-3, the first time in 1980, generalized anxiety disorder was introduced. So this is the historical aspect, how it was evolved. In DSM-1, as I mentioned, anxiety reaction. 2, it was considered as anxiety neurosis. In 3, it was considered as a generalized anxiety disorder, or if these symptoms presents for 1 month, and they differentiated it from panic disorder. But in DSM-4, it was considered the 6 months should be there, and that continued even in DSM-5. If you look at the classificatory system, both DSM and ICD, if you look at this, the duration has changed in 3 to 4 or 3R. It is from earlier it was 1 month and it has been increased to 6 months. At the same time, if you look at the number of symptoms, earlier it was the symptoms from 3 of the 4 categories. But however, in 3R, it was considered as at least 6 of the 18 symptoms, and in 4, 3 of the 6 symptoms. So this is how the DSM has evolved with regard to generalized anxiety disorder. But however, in ICD, there was a huge difference. In ICD-10, it was considered as a free-floating anxiety, but the day-to-day worry was not introduced. But in ICD-11, it was considered that we need to use this worrisome or day-to-day worry or worry about multiple events of the day. Then it was considered as GAD. So that played a crucial role. But however, there are various studies which talked about the prevalence and at the same time the diagnostic criteria. Whenever the diagnostic criteria changed from narrow to broader, the prevalence increased. And if it is from broader to narrow, the prevalence decreased. You can see here the DSM 3R versus DSM 4. Since the DSM 3 was broader, the diagnosis was very high. DSM 4 being very narrow and the number of symptoms were reduced, it became low. So the prevalence reduced. This clearly indicates the varying prevalence of generalized anxiety disorder is directly dependent upon how generalized anxiety disorder is diagnosed. So further, if you need to understand the generalized anxiety disorder has changed over a period of time, that means it has not changed. The way we have understood has changed. The way the duration of illness, earlier it was 1 month, now it is considered as 6 months. And in ICD-11, they introduced excessive worry. In DSM-4, it was there from the beginning. The number of symptoms, and earlier it was considered if there was depression, GAD cannot be diagnosed. But now it is considered that depression and generalized anxiety disorder can coexist. And relaxation of the criteria played a role in the evolution of generalized anxiety disorder. If you look at this historically, the important evolution, if I understand, there are 2 important things. One is there should be a general apprehensiveness or worry about the day-to-day events. That is very, very core important point. If there is no free floating anxiety, at the same time, worry for every day, for every matters, that clearly clinches the diagnosis. If you do not understand this pathognomonic feature, it is very difficult to diagnose generalized anxiety disorder. Let's understand how GAD diagnosis was questioned. Generalized anxiety disorder has changed many times. That is, basically, people have questioned the validity of this diagnosis because the generalized anxiety disorder has been classified under anxiety disorder, but the autonomic symptoms are very few. That raised the first question. The second was there is a presence of anxiety symptoms, and this anxiety symptoms cuts across many disorders. You can take social phobia, agoraphobia, panic disorder, not only that, even personality disorders, and also obsessive compulsive disorder. This led to poor inter-rater reliability with regard to diagnosis. That means the agreement when a psychiatrist makes a diagnosis of generalized anxiety disorder, then the other psychiatrist will accept is very less. At the same time, the higher rates of comorbidity, that means the studies have clearly said that the lifetime prevalence of comorbidity with generalized anxiety disorder is somewhere around 70 to 90%. That means invariably generalized anxiety disorder by default have another coexisting psychiatric disorder. Hence, the diagnosis GAD will be missed and the comorbidity will be diagnosed. Further, this temperamental history, that is anxious, shy, or else even separation anxiety, all these also come into picture. Further, AAPD, anxious avoidant personality disorder versus generalized anxiety disorder. Sometimes it becomes very difficult to delineate between each other. But at the same time, AAPD coexists with generalized anxiety disorder. Hence, it is considered as a residual diagnosis. And many a time, it was never considered as a separate diagnosis, or else the GAD was never made a diagnosis in the presence of other Axis 1 diagnosis. Hence, the validity of generalized anxiety disorder was questioned every time. So, over a period of time, the categorical nature of the classification was brought in so that we will be able to pick the symptoms, name the symptoms, and quantify the severity. And hence, generalized anxiety disorder became a categorical in nature. At the same time, one need to understand the pathognomonic feature of generalized anxiety disorder. Let's understand how generalized anxiety disorder is diagnosed under DSM-5. Here, there are very important features have been mentioned. The first and the foremost, it talks about excessive anxiety and worry. This excessive anxiety and worry, you are able to understand the excessive anxiety. The worry means apprehensive expectation. That means negative expectation of day-to-day events. Something may go wrong. And this should occur most of the days in 6 months. That means the person should have this anxiety, worry for most of the days in 6 months. And the number of worries should be in many dimensions. It may be such as work, daily chorus, finance, health, school performance. If there are there in multiple areas, the diagnosis becomes very easy. Further, the individual finds it very difficult to control these worries because he spends huge amount of time thinking about this day-to-day mundane worries. To think about this problem or unpleasant things that might happen in a way that makes you feel unhappy or frightened, that is the worry, and at the same time negative outcome wears them out on day-to-day basis. And the third important is the anxiety and worry are associated with three. At least three should be there in the 6 symptoms. What are those 6 symptoms? Restlessness or feeling on edge. That is very essential. That is being on edge, easy fatigability, difficulty in concentration, or else mind going blank, irritability, muscle tension, and sleep disturbance. If you look at these symptoms, you clearly can understand. Some of the symptoms are also shared by depression. For example, being restless, that is agitated depression, easy fatigability, that is also a A important pathognomonic feature of depression, difficult to concentrate, irritability, and sleep disturbance. That means the generalized anxiety disorder and depression overlap. That means it becomes very difficult to diagnose. But however, if you look at in children, one symptom is required, not all the three out of six. Hence, generalized anxiety disorder becomes a challenge for any physician. Further, there are exclusionary criteria have been placed after these anxiety should be coming in the way of biological function, social function, and occupational function. These anxiety should not be attributable to the substance, medical condition, and also other psychiatric disorders. That means this anxiety should not be attributed to phobic disorder, panic disorder, OCD, PTSD, BDD, eating disorder, delusion, or schizophrenia. So, the exclusion criteria has been very clearly placed. That leads to the diagnosis of generalized anxiety disorder. Now, let's understand the recent ICD-11, how the generalized anxiety disorder has been placed. First and the foremost, it talks about marked symptoms of anxiety manifested either as a general apprehensiveness that does not restrict to any particular environment. That means there should be a free floating anxiety. It clearly says that it cannot be phobia or specific situation related anxiety. It should be free floating and general apprehensiveness. Further, it also says that excessive worry, that means apprehensive expectation, negative expectation about the day to day events. And it can be in several areas. It may be work, finance, health, family. If there are multiple worries and it is majority of the days it is there, then the diagnosis becomes easy. Further, anxiety and general apprehensiveness or worry are accompanied by additional characteristics. What are those characteristics? First and the foremost is muscle tension or motor restlessness. Further, the ICD gives some amount of importance to autonomic overactivity, such as abdominal distress, heart palpitation, sweating, trembling, shaking, and or dry mouth. Along with this, there should be nervousness, restlessness, or being on the edge, difficulty to concentration, irritability, and sleep disturbances. Again, these symptoms should not be transient. It should be present and persistent over several months. Unfortunately, ICD-11 does not talk about the duration. The DSM-5 talks about 6 months. ICD is not clear about that. And again, the exclusionary criteria clearly says the symptoms of anxiety or worry should not be attributable to any mental disorder, any substance use, medical condition, or substance withdrawal related. So, these are the exclusion criteria. But however, the symptoms should result in significant distress, impairment in personal life, family life, social life, educational, occupational, and other areas of functioning. So that means here also the ICD-11 talks about impairment. With all these DSM-5, ICD, and various diagnostic category, it becomes very difficult to diagnose GAD. The simple reason is generalized anxiety disorder overlaps with either depression, personality disorder, or also normal worry. But let's understand the pathognomonic features of GAD. Excessive free floating anxiety should be there. And this anxiety should not be part of any stimuli or any other psychiatric or medical condition. That's the very important. Second, there should be uncontrolled worry. That worry is about day-to-day events. And this worry should be in multiple areas. It can be work, it can be finance, it can be health, it can be regarding children, it may be regarding the education, may be regarding the parents. And this worry should be at least for 6 months. Further, there should be some anxiety symptoms, which at least 3 of them should be there. Being on the edge, muscle tension, irritability, insomnia, easy fatigability, and impaired concentration. So, whenever you make a diagnosis of GAD, you need to keep this important thing in mind. One is free-floating anxiety, uncontrolled worry, which is there at least for 6 months. But you need to understand the GAD is very difficult to diagnose. And this GAD was introduced first time in 1980. Although the diagnosis is categorical, the symptoms have been counted, but this GAD continues to haunt the clinician. The simple reason is poor inter-rater reliability. But suspect generalized anxiety disorder when the patient reports of non-specific somatic symptoms. Why? The simple reason is many a time the patients from various culture may not be able to express anxiety. They will express anxiety in the form of somatic symptoms. It may be feeling tightness in the chest pain, tremblences, tremors in the hand, feeling of out of space, or else jumping out of the skin. These kinds of non-specific somatic symptoms are given. Then check for GAD. Let's understand. What is the epidemiology of generalized anxiety disorder? How common is it? Why should we know about generalized anxiety disorder? There are various studies have been done. Especially the lifetime prevalence of generalized anxiety disorder is 6%. That means out of 100 people, 6% of them, 6% will have GAD. If you look at the 1 year prevalence, the generalized anxiety disorder is 3%. And generalized anxiety disorder is the most common anxiety disorder in primary care. Not only that, you need to understand, as I mentioned earlier, as per the diagnostic criteria, the prevalence also varies. At the same time, if you look at the prevalence over a period of the age of onset or the age group, if you look at it, at the less than 24 years, the prevalence is very, very less. It is 1.5. Between the age group of 25 to 34, the prevalence increases to 6. Between the age of 35 to 44, it still remains at the 6. And if you look at the more than the age of 45, again, the prevalence will be somewhere around 3.6. That means GAD is not an early onset illness. It is somewhere around the third decade, the generalized anxiety disorder starts. You need to understand this very clearly, because by understanding the onset of generalized anxiety disorder, you'll be able to differentiate between the personality disorder, like dependent personality disorder, or else anxious avoiding personality disorder. So, if it is early onset, you may have to consider comorbid personality disorder, or else if it is late onset, that is around the third decade, then generalized anxiety disorder will be the first diagnosis. So the age at onset is 30 years. And if you look at the percentage, only 25% of them, the onset will be before 18 years. Invariably, they will be associated with a personality disorder. Considering that most of the diagnosis which occurs after 20 years, that means it is easy to rule out personality disorder. But however, GAD is very common in female. That means the gender plays a very important role. Female to male ratio is 2:1. At the same time, if you look at the severity, 70 to 77%, the severity ranges from moderate to severe in nature. But who are those people who are at high risk of developing GAD? That is woman, individual of low socioeconomic status, broken family, cumulative childhood trauma and adversity, those with the family history of generalized anxiety disorder, those reporting stressful life events in childhood, adulthood, they are highly prone to develop generalized anxiety disorder. Let's discuss about comorbidity. Comorbidity is nothing but having one more psychiatric diagnosis along with generalized anxiety disorder. If you look at the current psychiatric comorbidity, that means if you take 100 generalized anxiety disorder today and look for another coexisting psychiatric disorder, 66% will have another psychiatric diagnosis. If you look at the lifetime comorbidity of a person who is diagnosed with GAD, 90% will have one more psychiatric diagnosis. Hence, the occurrence of pure generalized anxiety disorder is somewhere 10 to 20% only. That means if you see a GAD, The rule says comorbidity is the rule. That means whenever you diagnose a GAD, out of 10 GADs, 9 of them will have one more psychiatric diagnosis. Further, the National Comorbidity Survey reported following comorbidities: depression, around 62% of them had; dysthymia, 40%; substance abuse, alcohol or alcohol dependence, other substances, 38%; social phobia, 34%; simple phobia, 35%. Further, the majority of persons with generalized anxiety disorder experience at least one other mental disorder at some point of time, and majorly it is depressive disorder. That means 90% have one or the other psychiatric diagnosis. But however, persons with GAD also frequently experience other medical conditions or physical conditions such as peptic ulcer, diabetes, irritable bowel syndrome, and recently they talked about cancer. Further, the earlier preliminary reports talks about asthma and various commonly occurring like hypertension and various disorders are also very common. If you look at the comorbidity, the GAD will be seen along with other disorders such as AAPD, OCPD, MDD, phobia, substance use, and other medical illnesses. That means comorbidity is the rule in generalized anxiety disorder. Let's look at the differential diagnosis. First and the foremost, you need to differentiate between pathological worry versus normal physiological worry. Here, the normal physiological worry is usually about a predominant stressor, which is there, and that stress is removed, the worry will go off. But however, in generalized anxiety, there will be abnormal pathological responses for everyday event or else even for a normal stimuli. Whenever there is a small event, the person will think that will be going into a negative catastrophic event. There will be abnormal threat perception, and also duration of response will be longer. That means up to 6 months. And further, they will think that there will be harm to the body or health. That means they also will have associated diabetes mellitus, hypertension, depression, and various other disorders. Because of this worry, there will be disability in the area of social functioning, occupational functioning, and biological functioning. That means it is easy to differentiate between the physiological and pathological. So please remember this. Pathological means abnormal threat perception. That means mundane, everyday event. The person who has GAD will worry. He will think that will go wrong, this will go wrong, and if I go there, something will happen. And something will happen means who will help me? So that kind of constant worry will be there. That worry will shift from one event to another event, and every second and every minute it changes. The next important is you need to differentiate GAD from OCD. In obsessive compulsive disorder, if there is a compulsion is there, it is easy to diagnose. But if you are going to see only predominantly obsession or else obsessive rumination is there, then how to differentiate? OCD, the age of onset is somewhere invariably between 18 to 20. And some studies which talks about 22. Whereas GAD, the onset is in the third decade. In OCD, this repeated obsessions can be auditory imagery or visual imagery. But at the same time, they may also have thoughts. Many of these patients who are having OCD, they feel these thoughts are senseless and they are about the day-to-day event and they know it is time consuming. Many of the time, they don't share these thoughts with anybody else because they know they are all stupid thoughts and they know they are imaginary. At the same time, they know that it is time occupying, they are repetitive, and set patterns they are able to say. And they clearly say it is difficult to control. Whereas in GAD, they say it is difficult to control those worries. In OCD, they will say it is difficult to control those thoughts. And they clearly say these are all unwanted thoughts. And invariably, if the compulsion is there, it is easy to diagnose. But however, one more important you need to differentiate, that is depressive ruminations. Especially in major depression or moderate depression, many of the patients will have depressive rumination. Again, depression, the onset, if it is less than 25, that means it is easy to diagnose that is depression. And many a time, this depressive rumination will be of the past events. What is there in the past events? In the past events, they will telescope only to the negative events. That went wrong. I am stupid. I have done wrong. I am guilty. And because of this telescoping only negative events, there will be depressed mood, suicidal ideas, suicidal attempts. So, in depressive rumination, please remember the worries will not be there. Here, they will be focusing on the past events only, past negative events. Whereas in GAD, it will be day to day events. Day to day events that will go wrong, this will go wrong. That is the apprehension they have. In depression, already something has gone wrong. That is the way the depressed patient puts it. That is the reason we call it as telescoping the negative events of the past. Further, one need to differentiate GAD from anxious avoidant personality disorder. In anxious avoidant personality disorder, it is most of the time the onset will be less than 18 years because it is a personality disorder. And invariably, the AAPD patients will feel they are inadequate, they are inferior, they will have fear of rejection by the others, fear of criticism, low self esteem, low self confidence is the characteristic of AAPD. Whereas the GAD is, the age of onset is in the third decade. But here in GAD, most of the time the patient will present telling that losing control over the worrisome thoughts. That means they are unable to stop this worrying thoughts. Here, it is nothing to do with the self perception. But unfortunately, the GAD and APD coexist. That means around 25 to 30% of the GAD patient can also have anxious avoidant personality disorder. Since the presence of comorbidity is very high, many a time it is difficult to differentiate these various diagnoses from GAD. In such time, you have to look for comorbid conditions. That means GAD can also be present with anxious avoidant personality disorder, in depression, or else OCD, or BDD, hypochondriasis. Hence, you need to understand this. GAD has higher comorbidity. With this GAD, we will understand what is the burden. There are two types of burden have been attributed and also measured. First and the foremost is human burden. The human burden is quantified. That means they quantify the impairment in role functioning and quality of life. There are two important things has been measured in human burden. That is impairment in role functioning and quality of life. Whereas economic burden, here the cost related to healthcare resource utilization and loss of work. That means here the burden with regard to economic is with regard to healthcare resource utilization, going to the hospital, travel, meeting the physician, consultation charges, medication charges, along with the loss of work. Both will be added to economic burden. There was an important study which did the review of human and economic burden published in Depression and Anxiety in 2008. This study is a meta-analysis of 34 studies looking at the burden of GAD. And this study clearly said that despite the differences in methodology and various study across the world, they clearly indicated GAD was uniquely associated with substantial human burden and economic burden. Further, by using statistical method, they controlled for various comorbidities such as depression, personality disorder, OCD. After controlling to comorbidities, GAD continues to be statistically significant with regard to human burden and economic burden. That means just because GAD has comorbidity, the burden doesn't increase. GAD as an independent diagnosis increases the burden, not only with comorbidity. Economic burden, if you look at that, 35 to 40% of the people with GAD had moderate to severe occupational role impairment. How much this impairment? That means every month, up to 6 to 7 days, they missed the work. That means they remained absent from work. Imagine, out of 1 month, if a person is unable to go for 1 week for work, that means 30% disability can be easily attributed. That means over a period of 1 year, you can say 1/3 loss of productivity, coupled with help seeking behavior, and also the loss of work burden. So if the national GDP, the GAD, if it is present, one third of the national GDP will be wasted. That means it has a high economic burden with regard to generalized anxiety disorder. Further, generalized anxiety disorder is associated with suicidal ideation. How many times? Sixfold when compared to general population. At the same time, the likelihood of attempt for suicide is 2 times than the general population. That means GAD has a high risk with regard to suicidal ideation and attempted suicide. Further, there was a one landmark study which looked into the 4-year prospective longitudinal community study of 22,548 adolescent and young adults. That means the children and the young adults between the age of 14 to 24 years. And they did a prospective study with regard to GAD. And they found that odds of developing depression in GAD is 4 to 5 times more than the general population. That means if you are seeing a GAD patient, there is a high risk he may develop depression in the near future. That means GAD is a high risk for developing depression. Further, there are many studies which clearly indicated GAD is associated with many medical conditions such as pain disorder, gastrointestinal disorder, cardiovascular disorder, endocrinal disorder, and respiratory condition. In one of the important WHO study from 14 countries from the primary care, in which 1 month prevalence of GAD was 7.9%. That is based on the ICD-10 criteria. That means if you look at the primary care studies, and 1 month prevalence is 8%. For every 100 patients who visit PHC, 8 of them have generalized anxiety disorder. Let's look GAD in the primary healthcare centers. GAD patients invariably present to the primary care doctors because of especially the nature of the illness, because of the constant worry or apprehensive which is persistently present. Hence, they go to the nearest doctor, that is primary care physician. Hence, if you look at the occurrence, it is the second most common psychiatric diagnosis in the primary healthcare settings. GAD is diagnosed up to 8% of the patient visiting the PHC. That means we have to look for GAD in PHCs. But you have to also understand GAD patients consult primary care doctors or physicians 5 times more than the general population. But they present with non-specific somatic symptoms. Many of our patients, especially in developing countries, they may not be able to verbalize the anxiety, such as, I'm having increased heartbeat, I'm worried, I'm anxious. They will not speak about that. Their distress is presented in the form of somatic complaints, such as chest pain, fatigue, generalized weakness. So that kind of symptoms will be presented. Not only that, difficulty in sleep, and also invariably tremors. So these are the presentation will be seen. But unfortunately, the diagnosis of GAD is made in 1/3 of the patient only. The studies have clearly indicated only 30% of the physician rightly diagnosed GAD. That means 2/3 of the patient, that is around 60 to 70% of the patient visiting PHCs never got the diagnosis of GAD, although they had GAD, resulting in wrong diagnosis, wrong treatment, delay in treatment, along with adding burden for buying those medication, visiting to the hospital for a wrong treatment adds to the economic burden. Now, how to improve the diagnosis of GAD in PHC? With regard to this, an international consensus group on depression produced a consensus statement that was published. They recommended 2 important screening questions to be asked by PHC doctors in every patient. That is, the PHC doctors should ask every patient visiting PHC these 2 questions. They are, during past 1 month, have you been bothered by feeling worried, tensed, anxious most of the time? So very simple question. In the past month, are you worried? Are you anxious most of the time? Second question is, are you frequently tensed, irritable, and difficulty in sleeping? So these are the two questions to be asked. Whenever they say yes, then you need to ask for GAD. Let's understand the neurobiology of generalized anxiety disorder. GAD has been conceptualized as a diagnosis which functions as a means to regulate affective discomfort. That means emotional dysregulation. In neuroanatomically, this generalized anxiety will be start from the amygdala. Further, the GAD also been attributed to the neurotransmitter imbalance such as serotonin, adrenaline, noradrenaline, catecholamines, steroids, and so forth. Further, abnormal HPA axis, hypothalamo-pituitary axis, has also been implicated because the stress response is mediated through hypothalamo-pituitary axis. That is, stress diathesis model has also been implicated. Further, the recent studies with regard to microbiota. The studies recently, they have even done the meta-analysis. And one of an important study which said that altered gut microbiome composition, that means lowered microbiota diversity. That is, dysbiosis of gut microbiota. That means the diversity of the microbes in the gut, if it is less, there is high possibility the patient will suffer from GAD, and hence this dysbiosis has been considered as a pathogenesis for GAD. The reason being, gastrointestinal system is considered as a second brain because majority of the neurotransmitters are also produced here. Further, GAD also has been implicated as a multifactorial in origin. The pathogenesis of GAD involves complex interaction between genes and environment, that is epigenetic phenomena. Various studies have implicated the pathophysiology of GAD with regard to various brain abnormalities such as frontolimbic neural circuit, immune dysregulation, neurotransmitter dysregulation, and also neuroreceptor abnormalities, starting with gamma-aminobutyric acid, 5-HTP, serotonin, neurotropic factors, and also immune-mediated cytokinins have also been considered. But however, genetic studies also been underpinning. Meta-analysis of family and twin studies reported that family members of patients with GAD were 6 times more likely to have GAD. That means, look at the numbers. 6 times. If one of the family member has GAD, the other person having GAD. Twin studies. The study which looked into the 63 monozygotic twins and 81 dizygotic twins, the concordance rate was 21% in monozygotic twins and 13% in dizygotic twins, indicating that genetics play a role in GAD. Further, there is an excellent review with regard to genetics of GAD. Please go through this excellent article looked into the genetics of generalized anxiety disorder. Summarizing this study clearly said that in candidate gene studies, partly combined with imaging and physiological readouts, the converging evidence clearly indicates some of the GAD susceptible genes with regard to serotonergic and catecholaminergic system, as well as BDNF gene has been implicated. Potential role of serotonergic candidate genes such as 5-HTT and 5-HT2A, as well as COMT and CHR1 genes have been implicated. Further, gene environment studies have also been considered. They have highlighted the importance of early developmental trauma, recent stressful life events in interaction with molecular plasticity markers and their combined relevance to GAD. Trait anxiety and anxiety sensitivity and various gene has been implicated. That means if there is early childhood adversity is seen, that means there is various genes have been expressed. GAD is a heritable condition with the moderate genetic risk. Approximately 30% is the heritable risk. That means the genetic risk is 30%, and of course, environment also plays a role. Hence, the childhood adversity plays a very important role. Let's look at the various neuroimaging studies. There was an important meta-analysis was done. That is, in Brazilian Journal of Psychiatry, 2019, it was published. They included 89 studies with regard to structural and functional neuroimaging studies in GAD, a systematic review. So they considered 63 activation study, 26 structural studies, 20 MRI, 5 DTI study, and 1 DWI study was considered. And if you look at this image, you will be able to understand the study's summary. First and the foremost, there is increased gray matter volume and hyperactivation in amygdala. Further, anterior cingulate cortex. Again, there is a increased gray matter and hyperactivation. Further, post-central gyrus have been implicated. Further, you can also see the gray matter volume and also hypoactivation is reduced in dorsolateral prefrontal cortex and also in the ventrolateral prefrontal cortex. So, the areas which have been implicated with regard to neuroimaging studies in GAD are ventrolateral and dorsolateral prefrontal cortex, anterior cingulate, posterior parietal region, and amygdala. Both in pediatric and adult GAD studies, this has been found. To summarize the neurobiology, this is one of the easiest way to understand. If you look at the severity of the anxiety and also presence of comorbidity has been placed in a format of step ladder. If you look at the x-axis, you'll be able to see the age. As the age increases, that is the way you can understand. And the genetic loading as the earlier the onset. That means there is a high propensity of genetic interplay. And if you look at the early childhood, internalizing symptoms and inhibition is there. Further, neurobiological and cognitive behavioral changes and sensitization. Increasing sensitization, avoidance, and developmental change can be considered. Further, persistent cognitive behavioral changes. So, here the interaction between the genetics, environment, childhood adversities, the perception of an event, and various other factors play a role in the development of GAD. Further, in the initial part, there will be the formation of subclinical anxiety symptoms, panic attacks, circumscribed phobia can be there. But however, separation anxiety, childhood anxiety disorders are commonly seen. That is how it starts. Further, comorbid complex anxiety disorder patterns will be seen, such as OCD, or else anxious avoidant personality disorder, dependent personality disorder, OCPD can be seen. 2. Because of these various things, the person will start doing self-medication by using substances. And finally, you may also see anxiety disorder, comorbid with depression. That is the way the lifetime development of GAD and various other comorbid conditions could be understood. Let's understand about the treatment of generalized anxiety disorder. So when we plan the treatment, you need to do a good history taking. The good history taking plays a crucial role to rule out other comorbid psychiatric diagnoses. Please look for depression, personality disorder, other anxiety disorder like panic disorder, phobia, somatization, BDD, even other psychotic disorder. Along with this, please do a thorough general physical examination to look into any other medical conditions which are triggering as an anxiety disorder. Please do lab investigation, hemogram, biochem with regard to LFT, RFT, thyroid functions, electrolytes, and if you are suspecting any medical conditions, ECG, echo, MRI scan, especially the GAD if there is an adult onset. Now let's understand the first line of treatment. The first line of treatment in GAD, the first line of treatment is dictated by the presence of comorbidity. Because out of 10, 9 patients will have comorbid diagnosis. Is it depression? Is it OCPD? Is it OCD? Is it medical condition? That will dictate the choice of medication. The first commonest medication chosen is SSRI, selective serotonin reuptake inhibitors, such as sertraline 100 mg, escitalopram 20 mg, paroxetine 50 to 100 mg can be given. Serotonin norepinephrine reuptake inhibitors, SNRIs, such as venlafaxine 150 to 225 mg, desvenlafaxine up to 100 mg, duloxetine up to 60 mg. So, SSRI or the SNRI can be considered as the first line of treatment. The second line of pharmacotherapy is based upon if the patient's anxiety symptoms is very severe, disabling, and the anxiety symptoms need to be controlled very fast, then benzodiazepine can be chosen, such as long-acting diazepam, clonazepam can be considered. Other medication anxiolytics such as buspirone up to 60 mg, pregabalin 300 to 600 mg, opipramol up to 300 mg, and many a time antipsychotics such as quetiapine has also been considered. However, to prevent the relapse of GAD, it has been suggested that pharmacotherapy should be given at least for 6 months to 1 year. That means GAD requires at least 6 to 12 months of medication. But however, in case of children, pregnant women, geriatric disorder, or else other medical condition, in such a scenario, you may have to choose psychosocial management. That may be cognitive behavioral therapy, can be considered alone, or else pharmacotherapy alone, or combination of both can be considered. However, if you look at the NICE guideline, they consider psychotherapy as the first line of treatment with regard to GAD. But however, one need to understand there are two important factors which indicates medication is the best choice. The first one is the presence of comorbidity such as depression, personality disorder, medical condition will dictate we may have to consider medication, or else non-availability of the clinical psychologist or psychotherapist also play a crucial role. Hence, I would choose medication first or the combination of medication and therapy. Although the antidepressant are the cornerstay of pharmacological treatment in GAD, only 50 to 60% of the patient respond. But however, 30 to 50% of the patient reach remission only. That means GAD is a chronic condition. Hence, combining the various treatment strategy play a crucial role in GAD. However, recently the research is also looking at the non-invasive brain stimulation research. There is one of the important review published in 2019 in Progress in Neuropsychopharmacology and Biological Psychiatry. The title of the study is Non-Invasive Brain Stimulation in Generalized Anxiety Disorder, a systematic review. When this review was done in 2019, they were able to identify only 4 transcranial magnetic stimulation and 1 TDCS study. So the preliminary results from these non-invasive brain stimulation studies, they clearly indicated dorsolateral prefrontal cortex, except in one of the study, along with the parietal cortex, has been considered and stimulated. And the early results clearly indicates that non-invasive brain stimulation do decrease the anxiety symptoms. And improvements and follow-up studies are hardly for 3 months to 6 months. Hence, in the short term, NIBs can play a role in anxiety. But however, we need to follow up this patient and see how long the treatment continues to be effective. Now, let's look into the GAD and psychotherapy. There is one of an important study, a meta-analysis was published in Cognitive Behavioral Therapy Journal in 2020. Here, the meta-analysis clearly indicated there are various types of psychotherapy has been considered. There are huge number of RCTs with regard to CBT. But however, the metacognitive therapy, acceptance and commitment therapy, mindful-based techniques, and various other therapies have been considered. Although this study indicates that psychotherapy plays a crucial role in GAD, but however, they clearly said that the placebo arm or else randomized control trial has been clearly considered the waiting list, which plays a very low role or the drawback with considered to RCTs. Hence, head-to-head comparison between psychosocial treatment or psychotherapy with pharmacotherapy is difficult. But however, combining pharmacotherapy and psychotherapy plays a crucial role. Further, there are studies with regard to yoga, meditation, and relaxation also play a role in GAD. Other treatment modalities such as exercise, physical activity, counseling, psychoeducation about anxiety, anxiety disorder, online self-therapy, anxiety confronting exercises in real life situation, use of self-help manuals also play a role. But recently I has mentioned which talked about gut microbiota. That means you need to understand there are some food may provoke anxiety. That means the food and nutrition also play a role. At this point of time, we do not have a strong evidence. But having a good lifestyle and healthy food play a role in management of GAD. Let's understand the course and outcome of generalized anxiety disorder. GAD is a long-term illness. There is a high chance of recurrence. GAD persisted for longer than 5 years in 40% of the individuals. During the 12-year study, the average amount of the time the patient spent in GAD is 74%. That means the patient spent in illness was almost 9 to 10 years. Further, Harvard Brown Anxiety Research Program, which clearly found in GAD after 2 years, 60% of the GAD subjects continue to have active symptoms, and at 5 years, 66% of the patient continued to have symptoms. That means they had only partial remission or no remission at all. Hence, it is easy to conclude GAD is known for its chronicity, waxing and waning course. Only 1/3 of the patient have a complete remission. And because of the high level of comorbidity, presence of personality disorder, medical disorders, all of these play a role in chronicity. What are the predictors of poor outcome? First and the foremost is family stressors, poor relationship with the spouse, parents, presence of comorbid axis 1 disorder like depression, panic disorder, agoraphobia, substance dependence, alcohol dependence, female gender, presence of personality disorder, presence of comorbid medical conditions play an important role in chronicity. What are the predictors of non-responder? Worse treatment adherence, the person who does not take treatment. High risk of relapse is seen in them. Greater risk of other psychiatric and non-psychiatric illness. Further, all these increases the healthcare utilization by twice compared to the treatment responder. That means one need to understand if a person does not take treatment regularly, if there is multiple relapses, further comorbid condition is present, there is a high chances will be non-responder for the treatment. To conclude, my dear friends, GAD is very prevalent in primary care settings. The prevalence is around 8%. GAD is more than just a tendency to worry and should not be ignored at all. You cannot just say a person, don't worry. Many a time GAD can trigger the physical illness. Consider GAD when patient presents with unexplained somatic complaints. Explain, explore, and see whether the person is suffering from GAD. GAD is associated with substantial distress and disability. GAD is often associated with other medical conditions and comorbid psychiatric disorders. Antidepressants such as sertraline are the first line of medical management. Psychotherapy and other psychosocial treatment are also considered to be effective. Of course, diet also play a role. GAD increases the chance of major depression, suicidal ideation, suicidal attempt. Hence, preventive approach should be taken in managing GAD. That means whenever you diagnose a GAD, be aggressive in treatment. If you don't treat GAD, there is high possibility the patient may also develop depression or else chronic medical condition. Hence, the individualized treatment on the basis of severity, anxiety arousal, somatization, comorbidity, and the acceptability of the patient with regard to treatment play a very crucial role in GAD. My dear friends, don't take generalized anxiety disorder very lightly. Understand about GAD, discuss the treatment management, chronicity of illness, and explore for comorbidities. That is GAD, my dear friends. Thank you very much for your valuable time. Stay safe.